Caring for Our Growing Aging Population by Araceli Soriano. In a healthcare system spearheaded by preventative care, resources are heavily allocated to those most at risk, pregnant women and children. Often, though, when considering the more vulnerable to disease, the spectrum also includes the aging population. It is estimated about 10,000 baby boomers turn 65 every day. Baby boomers referring to people born between 1946 and 1964. As these 10,000 individuals a day age into retirement, society as a whole has an equal obligation to ensure this population is equipped with all the resources necessary to continue living healthy lives and to improve health outcomes for those already being treated for chronic conditions. Social determinants of health set a precedent for mortality, morbidity, life expectancy, health expenditures, health status, and functional limitations. Assessing the social determinants of health of this population is a way of determining how health may be affected by environmental factors, such as economic stability, neighborhood and physical environment, access to education, food, community and social context, and a healthcare system. The dwelling environment and surrounding circumstances play a crucial role in determining the health of individuals, families, communities, and populations. This is especially true for the rising geriatric population as more and more of our elders move into retirement and experience a dramatic social change, parting from their employment, learning to live on a fixed income, adopting a new social climate, etc., all while managing chronic disease or attempting to maintain their health in good standing. Stressors such as poverty, access to basic necessities such as food and shelter are among contributors to the decline in physical health for the elderly. A review of elder insecurities that included poverty, hunger, and malnutrition cites between 8% and 16%, or approximately 2.5 to 4.9 million of the aging population across all economic and racial groups to have experienced food insecurities within a period of 6 months. Considering the rising cost of living and the fact that pension allowances have remained the same, as well as cuts of $8.5 billion to the Supplemental Nutrition Assistance or SNAP program, it's for certain the number of struggling elders has significantly risen and is only expected to continue to rise. Additionally, the review of elder insecurities makes reference to a direct link between rising healthcare costs and poor nutrition, noting malnourished elderly patients experience 2 to 20 times more complications, have up to 100% longer hospital stays, and compile hospital costs of $2,000 to $10,000 higher per stay. Alarming statistics in terms of morbidity and healthcare expenditures. Among the aging population, financial hardship, debt, and lack of social integration are among stressors that negatively affect mental health and can develop into comorbidities. Statistics show cognitive impairment affects 20% of those aged 65 and older and 45% of those aged 90 and older, a percentage that generally rises with age. A study of cognitive impairment and social engagement found cognitive impairment and social support are independent risk factors for mortality in the aging population. The study concluded interventions that promote early identification and management of cognitive impairment and enhance social support for older people may decrease mortality, highlighting a direct link between mental well-being and mortality. Other external environmental factors to consider are crime, safety, discrimination, and environmental pollution concerns that the elderly do not have direct control but directly impact their well-being. A profile of older Americans from the National Sheriff's Association notes, in 2009, 30.1% of older adults, or 11.4 million, lived alone, a number increasing with age. Fear of being mugged, being burglarized while at home, being attacked while driving, and being afraid of walking alone at night within a mile away from home were among other concerns cited. According to the same report, fear of crime is higher among older adults than the younger population, a paralyzing fear to the point where many older adults become afraid to leave their homes and withdraw from friends, family, and activities they once enjoyed. Change to improve the lives of our aging population begins with a change in perception. Because our federal government has implemented programs for the benefit and future of our aging populations, programs such as the Social Security Fund and Medicare, we tend to believe our geriatric population is well taken care of. We become focused on what they have access to, such as medical services and a steady income, that we forget what they lose. When retiring, our elderly lose their profession, their socializing networks, their ability to earn a livable wage, their independence, mobility, confidence, and more. However, aging is not only about losing, but also gaining. Gaining of negative thoughts, such as feelings of being a burden to others, fear or embarrassment to seek help, and other sentiments echoed throughout folks. While our healthcare system remains poorly equipped to address the social determinants of health that negatively affect the geriatric population, and while a solution may remain ambiguous and years away, there have been some systems put in place that have improved coordination and the quality of the delivery of care. One example is Medicare's Comprehensive Care Coordination and Case Management, a benefit directed to people with advanced chronic illness and debility. However, as the statement indicates, it is solely care coordination aimed at a specific subgroup or subgroups, primarily for the purpose of maintaining or lowering healthcare costs while still providing comprehensive quality services. Typically, eligibility for this type of care coordination is based on the diagnosis of the chronic illness or illnesses, and it is restricted to medical services including PCP, specialty, pharmacy, durable medical equipment, and community-based organizations as deemed necessary. It does not address the remaining pool of individuals that might not necessarily need the extensive coordination of medical services, but rather assistance transitioning due to a major life event, as is retirement. Engel, in his review of the federal budget cuts to the SNAP program, states, federal programs to combat food insecurity reach only 1/3 of needy elders, where efforts are needed to reach the folks like the remaining 2/3 not reached by these programs. One sensible solution would be to incorporate a transition program for the geriatric population for situations such as moving from a working lifestyle into retirement, or perhaps transitioning from living with family to living alone, or from living alone to moving to a senior community. Patients released from hospitals receive a transition plan following discharge to ensure they are able to return to their daily activities with little to no interruption, and to avoid a relapse or recurrent hospital stays. Similarly, the elderly would equally benefit from such a plan to help them cope and become adjusted to a new style of living. Through healthcare, patients receive a lot of pertinent health education such as nutrition, children and teens receive anticipatory guidance and safety prevention, expectant mothers receive breastfeeding and prenatal education, and so forth. Aging folks could likewise benefit from competency or education on moving from one stage of life to the next. As healthcare administrators, we could move forward to an even bigger enterprise where we would incorporate empathy to coordination of care while simultaneously broadening the scope of healthcare for the delivery of medical services to a comprehensive network of well-being. Adopting an approach where we would be interested in the patient as a whole and not solely on their medical needs. We would be receptive to their situation, assess possible social and environmental factors that could potentially influence their health, and suggest avenues or resources for help in an effort to reduce disparities among this disadvantaged population. Lastly, we could integrate this as an essential part of care and offer this support to everyone, regardless of their diagnosis or whether or not they fall in the category of a chronic illness. Healthcare is comprised of a wide spectrum of factors that directly influence physical and mental well-being. Environmental factors such as the social determinants of health, a balance and economic stability, neighborhood and physical environment, access to education, food, community and social context, and a healthcare system play a pivotal role in determining if an individual is predisposed to factors that can negatively impact health. This is especially true for the aging population as they transition from an active to a more sedentary life, a major life event. Through this transition, many elderly folks fall through the cracks and with limited assistance often face a number of disparities that in turn affect their health. Enhanced care coordination for all and an emphasis on empathy is a humble beginning. There is much room in healthcare to address these disparities while concurrently addressing rising healthcare costs to ultimately improve health outcomes for this frail population.